Good afternoon. It is right at 2 o'clock Eastern time, so we're going to go ahead and get started today. Welcome to week 4 of the Retention Academy. Thanks so much for being here and taking the time out of your busy schedules to join us today. I'm Suzanne Spear, Director of Workforce Development here at ECU, and I'm one of the faculty members from the STAR Center team, and I am joined by Mariah Blake and Ann Hogan. Today, we are delighted to have some guest faculty from Community Health Center, Inc. today to join us and talk about how team-based care can help to reduce provider burnout. Just a few webinar housekeeping items here today. We are recording today's session, and we will be posting a link on the discussion board after today's session. Feel free to ask questions as we go along, and don't forget to have some fun. So if you do have a question, feel free to raise your hand in the Go To toolbar, and put your question in the chat or questions box at the bottom of that toolbar there. If you have any technical difficulties or any connection questions or concerns, please email them to Mariah Blake at mblake@clinicians.org. Okay, so let's get to it. I'll hand it over to Anna Rogers from CHC Inc. to introduce our speaker today.
Great, thank you so much, Suzanne. I hope you can all hear me. This is Anna Rogers. I'm the project director for our National Cooperative Agreement on Clinical Workforce Development here at Community Health Center, Inc. We are the other National Cooperative Agreement on Workforce Development, and our focus is on pipeline development. Dr. Veena Channamsetty is here with me today. She is our Chief Medical Officer here at Community Health Center, Inc., and she will be leading us through today's presentation, so I will hand it over to Veena.
Thanks so much, Anna, and thank you so much for inviting me to speak today. I just want to quickly go over our objectives today. We are going to identify the core and extended care team members. We're going to talk a lot about how the team can support the clinician. So I think it's important to define that team and their roles in it. So likewise, the second objective is understanding the roles of the core team and how they can support the delivery of care and the clinician, and also understand how the extended care team can support the clinician. And of course, dive a little bit into how building a system can also support our clinicians. Okay, great. So wanted to just spend a quick minute and just talk a little bit about who we are, the Community Health Center, Inc. CHC is the largest federally qualified health center in Connecticut, really grown from an activist movement. We used to be one single dental chair in 1972 and now a statewide organization that really encompasses 90% of the state of Connecticut. We have 14 brick and mortar sites. However, we really do practice the model that many times, care needs to be delivered where the patient is. And we call that model WIA, W-I-A, wherever you are. And at first was really specific to our healthcare for the homeless. We have shelters throughout the state, but it really also represents our school-based health centers. We are in 180 schools throughout the state. And so between our brick and mortar sites, our mobile sites, our WIA sites, CHC has about 200 care delivery sites throughout Connecticut. Foundation to it all, of course, is a commitment to clinical excellence, delivering evidence-based care that is fully integrated and that is team-based. We are duly recognized by the NCQA as a patient-centered medical home level 3, and also recognized by the Joint Commission as a primary care medical home. The Weizmann Institute is a formal research institute that we have embedded into community health. We're continuing to study and improve upon care delivery, and you'll see how this also plays a role in engaging the front line and staff, in addition to senior leadership, in the larger picture of quality initiatives and being able to be involved in research, development, and publication. Finally, we know that in addition to delivering primary care and contributing to the field through research and development, we also have a responsibility to train the next generation to this model. We developed the nation's first nurse practitioner residency through the vision of our Vice President, Dr. Margaret Flinter. It is a one-year postgraduate training for nurse practitioners who have committed to community health. We also have a postdoctoral training for postdoctoral clinical psychologists and train multiple healthcare professional students throughout the state at our sites. And this also has a role in the support of clinicians in front lines through professional development. So today, our webinar is really going to more focus on looking at how team-based care can play a role in supporting the clinician and help to reduce burnout of our clinicians. Great. Let me see, okay, sorry. So I'm sure, as we kind of think about burnout, many on this call have already looked at the literature, what's out there, what's been proven to work, and I think by now everybody knows that more research is actually needed. There are a few good studies out there, especially specific to PCMHs and team-based care. Here are an example of a couple of them. The study on the VA was especially good, although parts of it was specific to being a VA system, but it did show in their investigation that there is a strong association with decreased burnout in specific things. One, not doing tasks that someone less trained than the clinician could be doing. Two, having some decision-making capability in the day. And three, staffing. So it was important in the study to note that years worked correlated with burnout. So time itself is a factor that increases burnout. But aside from that, it did show that there could be lower rates of burnout achieved in a medical home model by really making sure that everyone on the team is working to the top of their license, and specifically the clinician does not feel like they are doing tasks that somebody else could be doing. So to really deliver this role of team-based care, I wanted to spend a couple minutes kind of talking about the team. There's the core team and the expanded team. So leveraging the core team is really what some people call also the teamlet. When we designed our pods, our teams sit in something called the pods. We designed them to bring the full extended team together. So this is kind of the full extended interdisciplinary team. The core team really is 2 medical providers. Each one has their own medical assistant, so 2 medical assistants and 1 registered nurse. They are at all times and always co-located and sit together throughout the workday. Sorry. This is just a quick picture of the pod itself, and while it does look like a typical workspace, it's important to note that this is the workspace, the only workspace for the core and extended care team. There is not a nurse's station, there is not a medical assistant section somewhere. Providers do not have to go looking throughout the building, where's my MA, where's my RN. They are co-located with their team, really allowing for shared communication and real-time collaboration. If a clinician needs something quickly in a patient, they can turn right next to them. They are co-located with their team. And we know that there is a clear correlation to decreasing burnout when there is an activated, engaged, proactive support team. So to just talk a little bit about that, let's jump into the role of the medical assistant. So when we think about supporting our providers and clinicians, the first thought that comes to our mind, of course, is their direct clinical support staff, who we know can really make or break the day for our clinicians. So the MA is probably the one that has the closest relationship with the clinician, works side by side throughout the day, every day with the clinician, and their role really should be thought about how to leverage them well beyond just the rooming of the patient and vitals of the patient. So really the MA role should be maximized, especially in planned care. It should go beyond just cancer screening. It should include disease screenings. They should be using delegated orders to complete point-of-care testing even before the provider enters, and because it's delegated, should be done without the provider having to ask. Between all the logistical stuff that the MAs are doing, faxing, scanning, paperwork, we do put an emphasis on the MAs having a defined role in panel management or population health, which I think many of us think is really the responsibility of the provider. But the reality is the MA has a very important role in population health, and we actually dedicate about 40 minutes bi-weekly for the MA to do population health. The MA should also be leveraged in follow-up visits, not just today's visits. And it does not have to necessarily be the medical provider's visit. The MA can be leveraged in follow-up nursing visits. For example, a follow-up diabetes visit with the nurse while the nurse is doing the foot exam component or the education component. We actually use our MAs as camera operators to complete the retinopathy screening at that visit. And of course, the final goal is to engage and activate the medical assistants. So they should really be part of these larger initiatives of the agency, the larger QI initiatives such as microsystems or other projects. And when identified and when appropriate, should really be leveraged to lead these projects. They are the front line, and an activated MA can make the difference of a smooth day for the provider. So just a little bit more about maximizing planned care that I just mentioned. We have to think about what does the provider themselves really have to do. And we have to remember that the provider has to address the reason for the visit. The team really can address everything else that is planned care. To do that effectively and capture everything we want to capture, they do need tools. This is just our example of one, but every health record has some alert system or registry or reports. We have developed this planned care dashboard. It is moved up to about 32 items now. It includes cancer screening, so the MA uses this, and it alerts her per patient to do cancer screenings, A1Cs, foot exams, BMI counseling, asthma control testing when due, HIV screening or hepatitis C screening when due, if the patient is on chronic opioids and a follow-up functional assessment is due, behavioral health screenings like depression or SPERS that might be due. All of this is alerted to the MA, and the MA has delegated orders to go ahead and complete this screening on behalf of the provider. Because it's important to remember that all of this needs to be done at the visit. It just can't be the provider that's doing it all, and that is an important role for the MA to embrace. A little bit more on the panel management by the team as well, and specific to the MA, but the nurses as well. So as I mentioned, as we move quickly towards population health, population management, and value-based care, it's very important to think about how your MA and RN will support this intersection, because it cannot be all on the provider. So we've created, our MAs use 4 clinical dashboards. The diabetes dashboard, hypertension dashboard, opioid dashboard. It really is population management. They can see their patient's dashboard as a population. They can reach out through this list if they see an overdue A1C, if they see uncontrolled blood pressure, if they see that a opioid taking patient is due for a functional assessment. So these are patients, the planned care dashboard captured them while they were at the visit. These are patients of a population management that they can outreach to if due. And because they have the standing order to complete it, they can bring in the patient and complete it on behalf of the provider. Always reach out to the provider if needed, but don't have to burden or need the provider to complete these tasks. The goals of panel management is the goals that we think about when we think about why our providers do panel management. It's really about reconnecting patients who may be overdue for follow-up and need to come back towards the clinical team, to ensure that our uncontrolled patients are adhering with the defined treatment plans that the provider has laid out for them, and to ensure that planned care is being met in these chronic disease patients. The benefit of having an MA, nurse, or team panel management outside even the provider is that it does not rely on the provider to do this set of tasks. So when the provider is doing their panel management, they can really go to a higher level of panel management because their team is able to address tasks by a delegated order. So nurses, of course, can provide a very high level of support to providers, and in many cases, they deliver care as an extension of the provider. The primary responsibility of nurses, of course, is to support the provider during the visit itself. But this really has to be looked at as not just as support, tell me if you need anything, but really they should be delivering parts of the care of the visit to lessen the burden on the provider. So an example would be, and it's a very common visit in primary care, a follow-up diabetes visit. So if you look at the big picture, the MA will have roomed this patient, done vitals on the patient, done all the planned care and screening on the patient, alerted the nurse that the patient is here, who can then come in, complete the foot exam on the patient, if due, complete any vaccinations needed for the patient, and based on what other needs the patient has and standing orders, she can complete other tasks such as insulin titration. This is all before the provider has walked in to see what the chief complaint is. So the reality is it supports the visit by delivering some of the care of the visit in conjunction with the provider. In addition to that, nurses at CHC, they also actually have their own schedule. They see about 10 to 11 patients. So these visits, called nursing visits, as many are aware, can be done by a delegated order or a standing order. So these are just some examples of our nurses' standing orders. They are very well defined and protocolized visits. And if you kind of look down this list, many of these are the very visits that end up being double booked in a provider's busy day. So, you know, the patient could not wait, needed to be seen, and ends up being a double book, an extra book, a slip-in, really stressing the provider out. So these are the exact visits that the nursing can support and take on for their provider during the day. They will always reach out to the provider if needed, but they have a protocolized standing order to complete the visit if the provider is not needed. So, you know, finally, we've talked about the support team, but it is important to also note that the clinicians themselves have a role in their own success and satisfaction. And, you know, I think, you know, I definitely see it regularly that team-based care doesn't come naturally to everyone. And a lot of times I have discussions with my providers and remind them regularly to use their team. You know, we go through charts or go through the day and constantly am saying, why didn't you ask your MA to do that? And why didn't you ask your nurse to do that? And you know your MA could have done that. So it is something that, you know, the clinician themselves need to be trained to and taught to. So yes, they're ultimately responsible for the patient, but they also do have to let the team support them. So they need to empower their MA and RN in being proactive and not create a culture that everything has to be asked. So for example, it's flu season and your nurse goes in and delivers the flu shot for someone that is due. There should not be a culture that the provider says, well, I didn't ask you to do that. That is why there is standing order and delegated orders. It is there to support the provider, and it is important to have that conversation with the provider. They have to remember to leverage their team beyond just vitals and vaccines. I mean, I think that's the basic of what the core team can do, but leverage them through these examples that we just talked about. And finally, it's important to engage them together in the big picture, especially the roles of population health and QI, because it's really to get into the culture that it is the team's patient panel. So it is also the MA's panel. It is also the RN's panel. It's not only the provider's panel. So it becomes the team's panel, leveraging care and tasks that need to be completed come much more natural. Oops. See if I can move this. I think I just lost the ability to advance slides.
Try it now. There you go.
There you go. Thank you so much. So I just wanted to bring up. I just wanted to bring up this print screen. This is an actual print screen of a visit out of our health record. PHI has of course been removed, and this is what a print screen. This is of a note of what kind of having team-based care leveraged can look like. So this is a pre-op. The medical assistant, using her planned care dashboards and alerts, saw that the patient was due for nutritional education, due for hepatitis C screening, and for things that and so she can alert the provider that these are due based off of the chief complaint. But also, she was also alerted to complete certain screenings herself. So you can see that she completed a depression screening, she completed a substance abuse screening, she completed a domestic violence screening. All of this under behavioral health is already pre-populated in the note from the screening that the medical assistant completed and has already been put into the HPI for the provider. And then towards the bottom of the note under general cardiology, you see where the provider started, and he can start right in with the reason for the visit, the pre-op, and did not have to be, quote unquote, burdened by all the screening that this patient was also due for. Next slide. This is another example. So this is an example of our of a well care visit, similar to the one we just saw. The medical assistant was alerted to the multiple required needs of this patient, including developmental screening, lead screening, vaccinations that are needed. And so while the chief complaint of well care visit is there, the completion and necessary tasks that the patient also needed is also there. And so you can see down below, it's populated the note, the PSC-17, which is a developmental screening that the MA completed, is already in the HPI. The MA has actually, they have standing orders to pull in the template for the provider. So we've created well child templates for 5- and 10-year-old physicals. She pulls that in, completes the screening, and a solid, 3/4 of the note is completed for the provider as they, before they walk in. It's just important to note that, this is completed as clinical tasks. This is not scribing. RMAs do not stay in the room and scribe for our providers, though that might be a successful model. We just need a little more research on it. But this is task completion. Next slide. Okay, so we've been talking, spent a few minutes talking about the core team, also the teamlet, but I do want to spend a little bit of time talking about the extended care team and how they also can support patient care as well. The extended care team is really the other team members: behavioral health, registered dietitians, certified diabetic educators, podiatry, chiropractors, and next slide. And if you really think about how much behavioral health disease coexists with medical, you will absolutely agree with the importance of co-locating behavioral health with medical. We've seen almost regularly the fact that, an acute or even a chronic behavioral health issue during a medical visit can pretty much put a halt to the day for the medical provider, adds a huge amount of stress to their day. So really the ability to have on-site behavioral health, or to be able to do a warm handoff where somebody is there to take on that part of the visit, is a tremendous value add for both our clinicians and for our patients. Next slide. In addition to that, we took it a step further, and we created a system where behavioral health staff are also alerted to patients in medical proactively. So these are just quick print screens of dashboards that our behavioral health staff have. So they get alerted to patients who are seeing the medical providers, and we can define what that criteria is. Right now, we've defined it as these 3 criteria: uncontrolled depression, having a behavioral health diagnosis on the problem list, being in chronic pain and or on opioids, and also the system noting that there is no behavioral health services in place. The behavioral health providers will be alerted that medical may need their help, and will then in-reach versus having to outreach, and in-reach to the medical assistant and say, oh, I see that, Dr. Huddleston's 10 o'clock may need me. What time can I go in there? And it's a huge support, because the medical day can be so fast, we can miss the behavioral health needs of our patients. Next slide. So likewise, and probably beyond the scope and time that we have today, think about leveraging that extended care team. Yes, the patient is always center in these roles, but each role does have a support role to care for and leverage during the medical visit or after the medical visit to kind of really supply that full team-based, patient-centered care for patients. Sorry, next slide. So I just want to spend a couple of minutes. It's important to note that support is more than just what the clinical support is. I mean, team-based care is a huge amount of support, but it goes beyond that. And though it's a little bit outside the scope of this webinar, it is important to note that clinicians, what drives clinicians can be very individual, but there are themes to consider, and you'll see it in these papers. And we talked about some of the clinical themes around working to the top of the license and appropriate staffing, but there's themes beyond that too. I don't think these are new to anyone. There's themes around professional development, especially newer clinicians. While they are, yes, trained in primary care, I think that, some primary care becomes very complex and lends to burnout, such as chronic pain. So we used Project Echo to tackle these hotspot, complicated primary care complaints. So our providers get didactics to these hotspots, so they feel like they have the tools to be able to address it during the visit. CME support, doing on-site CMEs, on-site education, and then actually granting CME so they can use it, towards their licensure is an important addition for clinicians. And if the interest is there, there should be some leadership development, some pathway to leadership that can happen through performance appraisals, conversations with their managers, but also being able to identify. So that is where these QI, being part of these QI initiatives and leading projects becomes really important. It's really a pathway of leading and recognition to develop further through the agency. Most providers, when asked, will say that one of their passions absolutely is teaching. We talked a little bit about having our own on-site residency and really leveraging our providers to be the preceptors for that, blocking their time so they have protected time to teach. And by teaching, I think we always hear that they themselves learn, and it has been a huge satisfaction for our providers to have precepting time with our residents. And of course, having the path to access other professional passions, such as research and development. They can work with our Weizmann Institute. They can work with QI initiatives. If you don't have the Weizmann Institute, when you think of how to improve upon a process, leverage your MAs, leverage your nurses, leverage your providers, because it is a part of that passion that some providers have of wanting to be involved in larger decision making of the care being delivered in their organizations and in their day. Next slide. So finally, I know that was a very fast kind of run through. Can we go to final slide? Thank you. Run through of looking at mostly how team-based care in a patient-centered medical home can support providers. Help burnout really by what we call sharing the care, sharing the burden, having defined roles and responsibilities of the core team member to really take those tasks off of the provider, ensuring that every team member knows those roles and responsibilities and are trained to work at the top of their license, given the tools and protocols to do so, and really individual to the organization, being able to build individualized professional support systems for clinicians outside of the clinical realm. So thank you. And I'm open to any questions.
Great, and I know that we had a few. Thanks so much to Dr. Channamsetty and Anna from CHC Inc. for joining us today. We really appreciate you being with us. And I know that we had a couple questions come through on the chat line, and we might have time to ask those. So, Mariah, would you mind reading those?
Sure. We had one come in towards the very beginning there, just asking about private spaces for documentation. Do your medical providers ever request private space for documentation, and how do you handle that question while trying to keep a shared co-located team workspace?
Yes, so not all of them, but some do, because I think the co-located workspace does not work for everyone, and we really are open about it from the point of recruitment. So when we recruit, we make sure that I absolutely go over the team-based care model. I go over our pod model. We take them through the site. I ask all of our candidates to at least spend 2 hours in the pod shadowing, just so they have a sense of that. So, we are really recruiting for those team-based care thinking providers that are okay with co-locating, okay with systems around them. But having said that, days get crazy. And so while there are no private offices, providers that do need to get to a quiet space, there's usually another pod that is quiet. Some of the buildings do have something called a flex office, where there might be meetings held or one-on-one meetings held, and they use that flex office for some quiet time. And sometimes, towards the end of each session, they will kind of finish off their notes in the exam room. But I will tell you, the majority of them do spend their time doing documentation in the pod itself.
Great, wonderful. And I know we had a couple more questions come in. We We are almost at time though, so we will take note of those questions that have come in, and we will respond via email to those questions because we know that those are important and we want to get those answered to you, also while respecting everyone's time here today. So, well, this has been a great presentation. I know we have a lot of probably a lot more conversation that can happen next week during our office hours. So the folks from CHC Inc. will be back with us to talk through our homework and also, again, answer any other questions that you might have after you've gone back and sort of had some time to digest this information. So we really appreciate those who have gone on the discussion board and uploaded their homework from last week. That's awesome, and I love the peer sharing that's going on there. So good job, continue that. And if you haven't had a chance to upload your homework yet, go ahead and do that. And look for an email from us this week about something, an optional thing that we have going on during this Retention Academy. We're going to be revealing some accountability partners. So again, it's optional, but just another opportunity to connect with the members of your cohort and to get some more out of your time here with us there. So again, thanks so much to the folks from CHC Inc. and for everyone for joining us today. And we will talk to you next week at 2 p.m. Eastern for office hours. Take care, everybody.
Thank you. Bye-bye.